The following podcast is part of a certified educational activity titled First Move Matters, Playing to Win in EoE, from emergency department recognition to continued care strategies. Access the entire activity and complete the post-test at peerview.com/SCE860. Downloadable slides and practice aids are also available.
Hello, everyone. This is Dr. Pooja Singhal from Oklahoma Gastro Health and Wellness Center in Oklahoma City. It is my pleasure to be a part of this educational activity, and I wanted to personally thank you for participating in this activity titled First Move Matters, Playing to Win in Eosinophilic Esophagitis, from Emergency Department Recognition to Continued Care Strategies. This CME activity begins with an interactive game to keep it fun and to assess and improve your knowledge about EoE, which refers to eosinophilic esophagitis, and the importance of recognizing it in the emergency department. After that, I'll review the signs, symptoms, and approach to diagnosing EoE promptly, the range of treatment options available, including targeted biologic therapy, and the importance of continued care to prevent patient loss to follow-up. And the common themes here throughout this educational activity would focus on eosinophilic esophagitis, the increased prevalence, and how important it is for us as care team to be able to capture these patients for early treatment and remission. So with that in mind, let's get started. During this presentation, we will learn that EoE can present in diverse and recurring ways, including food impaction, dysphagia, and vomiting. Emergency department protocols can really help guide next steps in care, such as referral to gastroenterology, endoscopy with biopsy, and follow-up to prevent long-term complications, recurrence of ER presentations, and ensure timely access to effective treatment. A range of treatment options are available for EoE, including biologic therapies and supportive care strategies. So let's talk about it. Let's talk about EoE, which refers to eosinophilic esophagitis. Firstly, it is a chronic immune-mediated esophageal disease characterized clinically by variation of symptoms related to esophageal dysfunction. And histologically, you see eosinophilic predominance causing inflammation. The prevalence of EoE is definitely increasing, but diagnostic delays are common because it's often confused with GERD, which is very, very prevalent. An important thing to keep in mind is that signs and symptoms can definitely vary a lot between children who have EoE and how they present, and adults who have EoE and how they present. And we'll discuss that a little bit later. EoE-associated visits to the emergency department have tripled from 2009 to 2019. And the patients, the way they present to the ER is with food impaction. Furthermore, these visits are projected to further double by 2030. So we all have to do a better job. Research has shown that a large number of patients who present to EDs with esophageal food impaction are lost to follow-up. Implementing protocols in the ER, in the emergency department, can improve biopsy, a proper diagnosis, referral rates, and ensure that patients receive timely treatment. With this in mind, let's begin the game portion of this activity and assess your EoE knowledge base. You will be presented with questions or scenarios and will be able to earn up to 1,500 points. Exciting, isn't it? You'll see your points and ranking among your colleagues as you proceed through the game. Question 1. Slide the arrow as I read this question. Here's the question. EoE is found in up to what percentage of patients undergoing endoscopy for dysphagia? So please slide that arrow ranging from 0% to 100%. All right, let us look at the results. Here's how you answer this question as compared to your colleagues. At the top of the screen, you can see how many points you earned and you ranked throughout the game. EoE has been found in 12 to 23% of patients undergoing endoscopy for dysphagia. Let us look at the second question. Which of the following symptoms should prompt an ED physician to consider EoE in the differential diagnosis for an adult? You can select all that applies. A, food impaction. B, shortness of breath and wheezing. C, dysphagia. D, epigastric pain relieved by antacids. E, acute hematemesis. Let's look at our answer. Among adults, eosinophilic esophagitis often presents to the emergency department with food impaction and or dysphagia. These features are key clues for EoE-related esophageal dysfunction. By contrast, wheezing, reflux-type pain, more common in pediatric patients, or GI bleeding point to other etiologies such as asthma, GERD, or ulcers. So please keep that in mind. With that, let's go on to our third question. Fill in the blank. Eosinophilic esophagitis is a T helper 2-mediated disease characterized by the overexpression of cytokines such as blank, which promote the recruitment of eosinophils to the esophagus, leading to chronic inflammation. So this question is testing your knowledge about your inflammatory pathways. First option, IL-33, IL-25, IL-23. The next is a combination of IL-4, 5, and 13. The next choice is IL-25, 17, and 6. And the last choice is IgE, IL-17, and 23. So please take a minute to fill in the blank. Let us look at the results. EoE is a T helper cell-mediated disease characterized by the overexpression of cytokines such as IL-4, 5, and 13, which promote the recruitment of eosinophils to the esophagus, leading to chronic inflammation and resulting in such symptoms like are presenting symptoms of dysphagia and food impaction. All right, hopefully those points on your screen are looking great. Let's move on to our next question. This is a fun drag and drop activity. So drag the steps into the correct order for diagnosing EoE. Our options are exclude other causes of esophageal eosinophilia, identify greater than or equal to 15 eosinophils per high power field, perform endoscopy, and the last choice is obtain esophageal biopsies. So again, we are dragging and dropping in the correct sequence of diagnosis. So the diagnostic algorithm for EoE starts with EGD, which is upper endoscopy, followed by biopsy to confirm eosinophilic predominant inflammation. And the eosinophil count that we're looking for is greater than or equal to 15 eos per high power field. Exclusion of other conditions, including conditions like GERD or infections, is crucial for a definitive diagnosis. And you're halfway there. Here's your score and ranks so far. Question number 5. Slide the arrow to indicate the percentage of patients presenting to the emergency department with esophageal food impaction who were sent home with no follow-up. Let's look at the answers. A retrospective study of nearly 1,000 patients presenting to the emergency department with esophageal food impaction found that 83.6%, that is correct, 83.6% were discharged with no follow-up, and only 7.2% went on to have an endoscopy, highlighting how we can really make a difference here by having ED protocols. Let's look at our next question. Here's the drag and drop again. Match each EoE treatment to its mechanism of action and associated efficacy. So on the left side, you have PPIs, swallow topical steroids, dietary therapy, and biologic therapy, which is dupilumab. And on the right side, you have options: reduces esophageal eosinophilia and inflammation, high doses, and lower symptom scores associated with greater efficacy, removes potential food triggers, effective but difficult to maintain long term, blocks IL-4, reducing Th2 inflammation and improving clinical outcomes, reduces acid and inflammation, induces remission in 50% of patients. All right, let us look at how that matches up. So PPIs, which are the proton pump inhibitors, reduce acid and inflammation, but have variable efficacy, inducing remission in about half of the patients. Swallowed steroids, on the other hand, reduce esophageal eosinophilia and also have varying efficacy with use of higher doses and lower symptom scores associated with greater efficacy. Dietary treatment is effective and acceptable long-term, but can be difficult to adhere to. Dupilumab is the latest new treatment. It is a biologic treatment that blocks IL-4 and addresses the underlying inflammation of EoE. Question number 7. Select the best answer. This is the last question. A 35-year-old man presents to the ED with a food impaction. He has a history of dysphagia, but no prior diagnosis. He reports no history of acid reflux. What is the next best step? A. Administer oral corticosteroids and discharge him to follow up with a gastroenterologist in 4 weeks. B. Refer for urgent endoscopy with biopsy to confirm EoE. C. Recommend a trial of PPIs. D. Provide a swallow topical steroid prescription and advise him to follow up with a gastroenterologist in 4 weeks. All right, let us look at the answer. Given this patient's food impaction and history of dysphagia, EGD with biopsies is the gold standard for diagnosing EoE and excluding other potential causes of esophageal obstruction. The biopsy will provide histologic evidence of eosinophilic predominant inflammation, which is essential for an accurate diagnosis. Delayed diagnosis and inadequate follow-up can lead to long-term complications like strictures and fibrosis, which can be extremely hard to manage. Congratulations on completing this game. Here's your score and rank. To learn more, please stay tuned for a presentation on strategies for recognizing and managing EoE in the ED, which will begin shortly. Welcome back. Leveling up EoE recognition. So let's start by talking about epidemiology of EoE. And throughout this presentation, EoE will be referring to eosinophilic esophagitis. So EoE is the most common cause of food bolus impaction. It is more common in males than females by 3-to-1 ratio. It is found incidentally in 2 to 7% of patients undergoing endoscopy for any reason, and I see this in my practice all the time. It's found in 12 to 23% of patients undergoing endoscopy for dysphagia as their primary symptom. A very important point to highlight here is the presentation of EoE differs between pediatric and adult patients quite a bit. So what does that look like? As depicted in this graph, ages between 0 to adolescent, so about 0 to 12, preteen, the main symptom can be feeding disorder, fussy eaters, vomiting, and abdominal pain. And as we go into the age group of late teens to adults, this presenting symptom really becomes more of abdominal pain, dysphagia, and food impaction. So that's a very important point to remember. Diagnostic delay in EoE is common. The time between symptom onset of EoE and diagnosis ranges from 1.2 to 3.5 years in children and 3 to 8 years in adults. Can you imagine that? A study of 705 patients with EoE from ages 6 months to 65 years revealed that this time gap increased as the patient age at diagnosis increased. Median time from symptom onset to diagnosis was 1 year in children less than 11 years of age, 2 years in patients who were 11 to 17 years of age, and 4 years in adults. It is important to remember that EoE can be associated with other diseases as well, mainly food allergies, atopic dermatitis. The presence in this particular study, the presence of food allergy and atopic dermatitis was associated with a more prompt diagnosis and was also more common in younger populations. So let us look at the pathophysiology now. How does eosinophilic esophagitis actually happen? Th2-mediated condition recognized by infiltration of eosinophils into the esophagus. So what happens is the activated T helper lymphocytes increase tissue levels of Th2 cytokines, mainly IL-4, 5, and 13. Remember our question from the game earlier? Interleukins 4, 5, and 13. You can see some of the foods, the environmental factors here. So you have food triggers, you have microbes, you have genetic susceptibility, leading to activation of Th2 cells and then activating IL-4, 13, and 15, leading to various ways of causing eosinophilic inflammation, loss of barrier, remodeling in the esophagus. So how do we diagnose it? Here is an updated EoE diagnostic algorithm. Once somebody is presenting with clinical presentation that's highly suggestive of EoE, you want to do an EGD and you want to do biopsies. That's very, very important. During EGD, there is something called an ERAF score, which is an endoscopic score to assess for eosinophilic esophagitis. At least 6 biopsies from different esophageal levels should be obtained. And at the biopsy level, if the esophageal eosinophilia is present, the magic number is greater than or equal to 15 eosinophils per high power field. If the biopsies reflect that, then you have your diagnosis of EoE. So let us look at the trends in ED visits from 2009 to the projected 2030. So this was mentioned earlier that the visits have doubled from 2009 to 2019, and you can see that in this graph. And it is projected that these visits are going to continue to rise because the incidence is increasing. Implications of treating and releasing from the ED. So treat and release from the ED may be appropriate for managing acute EoE-associated visits, but this strategy is dependent on adequate outpatient follow-up evaluation. And I can tell you from personal experience, these patients are very, very easy to get lost and they don't want to follow up. So it's important that we all recognize that and work on that. Historically, a significant number of patients with EoE have been lost to follow-up, setting the stage for ongoing uncontrolled esophageal inflammation, progression to fibrostenotic phenotypes, increased risk of disease-related complications such as food impactions that require ED care. So let's look at a retrospective study that focused on delayed diagnosis of EoE in patients presenting to the ED with esophageal food impaction. So there were 938 patients enrolled, and out of those patients, subset who presented to the ED with food impaction, 83.6% were sent home with no follow-up. Only 7.2% went on to have an endoscopy. That is such a loss because those numbers are pretty astounding. In those with macroscopic evidence of inflammation, only 35.8% of patients had the correct number of biopsies taken to establish a histological cause of their symptoms. So this slide highlights a protocol to improve the management of esophageal food impaction. So this is a protocol that showed after implementation at a multi-center behavioral intervention, they had improvement in biopsy rate. Implementation of a standardized protocol for esophageal food impaction management led to a significant absolute increase in food impaction biopsy rate of 39.8% and 43.1% at two different healthcare systems. So here you can see on that graph, in system A, you have an increase here from 35.2 to 75, and in healthcare system B, you have an increase 39.3 to 82.4. Post-esophageal food impaction management also improved, suggesting this behavioral nudge is replicable and a meaningful strategy to improve adherence to best practices in EoE care. So targeted education and updated workflows improve biopsy rates and expedite referral for EGD. Core goals of a quality improvement project at Boston Medical Center, their goals were facilitating screening of patients presenting to the ED with symptoms of EoE, including referral to appropriate specialists and/or endoscopy biopsy. Aim was to improve the average time to diagnosis for patients with EoE after presentation to the ED for dysphagia or food impaction. Remember that we reviewed the average delay in diagnosis in adults for EoE is about 4 years. Promote timely diagnosis of patients with EoE by obtaining biopsies at the time of initial endoscopy if feasible, and reducing the number of patients lost to follow-up by providing additional supportive resources. So interventions, clinical education, patient education, and operations. For ED, recognition and triaging of EoE. For GI, regarding importance and safety of biopsies during index endoscopy. Patient education, resources for patients regarding esophageal food impaction, and importance of follow-up, translated into multiple languages. And then operations included building a rapid referral process allowing ED providers to order expedited endoscopy. So what were the results? Pre-intervention, 44% of eligible patients biopsied, and please note the N is 9 here, so that's the number of patients. 1.2% of eligible ED patients with N of 78 presenting with dysphagia were referred for EGD, and post-intervention, 100% of eligible patients were biopsied. 16.2% of eligible ED patients presenting with dysphagia were referred for EGD. So let's talk about the power of modern treatment options in EoE. So here is the accepted management algorithm with updated guidelines from American Journal of Gastroenterology. These were published earlier this year. So once an EoE diagnosis is established, our goal is to treat inflammation and assess for fibrostenosis in all patients. Once we do have remission and relief in symptoms, maintenance therapy and long-term monitoring is key, because this is a chronic immune-mediated process. So that is also a very important aspect of managing this disease. So take-home points: reassure patients that although EoE is chronic, it is treatable. Emphasize that treatment can significantly improve symptoms and reduce the risk of esophageal complications, such as strictures or food impactions. So to summarize that algorithm, because that was quite busy, let us just look at this way. First-line approaches to treating EoE: PPIs, which obviously refer to proton pump inhibitors. Their anti-secretory, anti-inflammatory mechanism is effective. Long-standing safety profile is present with PPIs. Their ease of administration and low cost is favored by patients. It does have variable efficacy. It induces remission in about half of the patients. Swallow topical steroids reduces esophageal eosinophilia. Histologic remission less than 15 EOS per high power field rates may vary depending on formulation, delivery vehicle. So they can vary from 15% to 84%. Use of higher doses and lower symptom scores associated with greater efficacy. It does provide a topical coating to the esophagus. So one important adverse effect to keep in mind with swallowed topical steroids is the risk of esophageal candida infection, also decreased bone density, adrenal insufficiency, and decreased linear growth velocity. And then dietary therapy, it's effective, acceptable for long-term treatment, but the challenge definitely is the adherence can be difficult. The newest treatment option is dupilumab for EoE treatment. It is the only targeted biologic therapy approved for EoE. Other biologic agents are under investigation, including tezepelumab, which is in its phase 3 clinical trial. So what are the considerations for first-line use for dupilumab? If there are multiple comorbid atopic conditions such as asthma, atopic dermatitis, chronic rhinosinusitis with nasal polyps, or there is a strong preference to avoid dietary restriction or swallow topical steroids. So that's the first-line use considerations. Considerations for use as a step-up therapy are that it is difficult to treat EoE patient. You've tried other things and it's not working. Patient is experiencing failure to thrive, poor growth, or significant weight loss due to EoE. You're having to use frequent rescue therapies. There are severe dietary restrictions or requirement for amino acid formula. There are clinically significant esophageal strictures or narrow caliber esophagus. Of course, if the disease is refractory to current therapies. And lastly, if the patient is experiencing a lot of adverse effects from other therapies like PPIs or swallow topical steroids. So let's look at this evidence here that was presented at DDW 2025, which is Digestive Disease Week. Biologic therapy associated with significantly reduced risk of food impactions and ED visits. Results of a real-world propensity match analysis showed that patients who received dupilumab had a significantly reduced risk of food impaction requiring upper endoscopy. So you have an odds ratio of 0.47 with a 95% confidence interval with a statistically relevant p-value of 0.01 and fewer ED visits with good statistics behind it compared to those treated with PPIs or corticosteroids. As with any other chronic immune-mediated disease, it's very, very important to personalize care for good outcomes and adherence. So let's look at that. Personalizing care in EoE. Facilitating diagnosis and preventing loss to follow-up. Key steps in the ED. This is where we need you to help us. Consider EoE in differential diagnosis for patients with food impaction, dysphagia, or unexplained chest pain. Implement ED protocol, example, rapid referral for EGD if there is one. If not, workup should include, in addition to clinical exam, perform relevant lab testing, example, eosinophil count to assess for underlying inflammation. EGD with biopsy is the gold standard for diagnosis. Make sure patients are referred to gastroenterology for follow-up. Ensure the patient understands the importance of follow-up to prevent the progression of the disease. And that's the key. Usually the patient, if they've had endoscopy urgently in the ED, will not remember. I personally, all the food impactions where I suspected EoE, I would go out and talk to their family member and make them understand how important it is to follow up. Action point: if no ED protocol exists, please encourage patients to follow up with a gastroenterologist within 1 to 2 weeks for a biopsy and further management. Provide them with written instructions and contact information for specialists. So, in summary, recognizing EoE, please consider EoE in any patient presenting with dysphagia, food impaction, or chronic chest pain. EGD with biopsy is the gold standard for diagnosis, and timely referral for EGD and to the gastroenterology is critical. Facilitating follow-up, providing patients with resources for following up with GI or dietitian or both is important. Ensuring patients are educated about the chronic nature of the disease and the need for ongoing management is also crucial. ER physicians play a very key role in multidisciplinary approach to treat and prevent complications of EoE. ED physicians can encourage and facilitate referrals to GI and allergy specialists for comprehensive care. So the action point here is your role in identifying potential EoE patients in the ED can significantly improve long-term outcomes by facilitating early diagnosis and timely follow-up. Thank you so much for joining me today and taking out the time. I hope you found this activity to be useful to your practice. Thank you.
Thank you for listening. Remember to download the slides and practice aids and complete the post-test for instant credit. This activity is certified by PVI, PeerView Institute for Medical Education. This activity is supported by an independent educational grant from Regeneron Pharmaceuticals Incorporated and Sanofi. To access all materials for this activity, visit peerview.com/SCE860.